thanks for joining us, Jiten. Can you please introduce yourself and give a bit about your background?
Thank you. So I am a consultant urologist with main clinical attachment in Portsmouth University Hospitals NHS Trust. And my main area of expertise is treating prostate cancers. I'm a fellowship trained robotic surgeon, and I also specialize in focal therapy for prostate cancer. And I'm also involved in treatment of radiotherapy recurrent prostate cancers, and can treat prostate cancer with robotic surgery, brachytherapy, HIFU, cryo, and all these minimally invasive treatments. And that's what my work is.
Fantastic. And thanks for agreeing to discuss the topic of treatment options for prostate cancer recurrence after radiotherapy. And just to start, how common is radiorecurrent prostate cancer?
So this is, if we look at actual numbers from US, so we know that prostate cancer is essentially among the commonest cancers in men. At least in the UK, it is the most common cancer among men. So most prostate cancers are actually treated with radiation therapy rather than surgery, both in India and abroad as well, in US as well. So when cancer recurs after radiotherapy, we would expect those numbers to be big as well. And surprisingly, in US, they believe that out of all other cancers, this is the fourth most common cancer. So prostate cancer being number one, and then radiorecurrent prostate cancer being fourth on the list. So it is as important as any other cancer. In UK as well, we treat 2 times patients with, 2x number of patients are treated with radiotherapy rather than surgery. So when they fail in future, I think they would form a substantial number as well, though we don't have exact figures from the UK, but this burden is potentially very significant.
Okay, interesting. And what are the definitions when you suspect someone has reoccurred after radiotherapy?
Yeah, so after radiation therapy, especially when we give hormone therapy along with radiotherapy, the PSA levels go down to a nadir value, and then they increase gradually sometimes as time progresses. So historically, we would follow the ASTRO definition, which would define biochemical recurrence as 3 consecutive PSA rises, increases from a nadir. But then later on, we found that this wasn't as good a definition, and a Phoenix definition was then adopted instead, which defines biochemical recurrence as a PSA increase of 2 nanogram per ml or higher from nadir with or without hormonal therapy. So for example, if someone's nadir or the lowest recorded PSA value with hormone therapy and radiotherapy was, let's say, 0.1, then I would say any PSA value of 2.1 or higher would then classify as biochemical recurrence. Although not every PSA increase means that a cancer has recurred. There could still be many other reasons for PSA to increase, but that's the trigger to investigate. So if someone's lowest recorded PSA value after, let's say, radiotherapy alone was 0.5, then 2.5 would be his value. So it has to be individualized in every case.
And what is the incidence of treatment failures after radiotherapy?
Yeah, so this is also a very interesting fact. So historically, I remember when I was a trainee way back in 2008-9, when I was an intern. So there was this interesting study where they did prostatectomy. So essentially they removed the bladder and the prostate for bladder cancer patients who had previous radiotherapy given for prostate cancer. Now, technically, 89% of those patients were cancer-free according to the PSA definition. But when those specimens were studied, 50% of those specimens had residual prostate cancer in them. So I mean, even with the PSA definition, we know that a lot of patients would be failing in the background with the PSA due to rise in future. So that's what the data in 2008-9 was. But then, of course, things have changed and improved over time. But even today, when we look at contemporary data, so we right now follow the hypofractionated regime. And if you look at the CHIP trial data, then the incidence of biochemical failure or clinical failure at 5 years in patients who had radiotherapy for T1B to T3 disease was around 10%. So 90.6% patients were failure free, but rest had their cancer recur. If we look at Stampede data, where we saw that in patients who were node positive, around 45% patients had failed treatment. In those that were node negative, around 25% had failed treatment over time. So like I said, this burden is quite significant, and there have been studies which have, people have gone ahead and biopsied these patients to see even if they did not fail. As per the PSA definition, we found that a positive biopsy rate, meaning that even though your PSA may be fine, but cancer might still be there, the positive biopsy rate in high-risk cancer after radiotherapy in a meta-analysis by Singh et al. Was found to be 29%. So nearly 1 in 3 men were failing treatment despite having radiotherapy and technically in the cloud of success with a low PSA value. And this has prognostic significance. So like I said, these numbers, if we actually formally audit them, are likely to be a surprisingly huge number. And in US, they already call it the 4th most common cancer after, index prostate cancer. Radiorecurrent is the 4th rank.
And I suppose moving on, what is the pattern of failure after radiation treatment, therapy treatment for prostate cancer?
Yeah, so this also is, again, as we understand cancer better and better, we are finding that this pattern has changed over time. So historically, when there was no PSMA PET scan, we would see that patient would have radiotherapy, and then some years later, you would suddenly see metastasis in other parts of the body. So we would think, okay, maybe these were occult metastasis, which we did not initially see, and now these are growing up. But now, as we follow these patients up more intensively, and now we have better scans and PSMA scan has come into picture, what we are seeing is that a lot of these patients fail first in the prostate, and then that recurrence in the prostate drives further metastasis. So what we are seeing in the PSMA PET scan era is that 40% patients would fail in the prostate, 40% would fail straight away systemically, meaning yes, there were occult metastases that grew up later just to become visible, and 20% would fail by PSA definition, but the scan would not show a disease anywhere. So now I say 40, 40, 20. So 40% within prostate, 40% outside, and 20% we still don't know where the cancer is, or maybe it's not there. But important thing is, the further you are from your point of treatment, and if you see that your PSA has started increasing, you are likely more guaranteed failing. It will not be a false positive rise. So if someone has had his radiotherapy, let's say today, and then his PSA starts increasing within first 2 years, that could still be due to many reasons. But if it starts increasing, let's say after 4 or 5 years, this is likely cancer coming back.
Okay, interesting. And how do we investigate someone presumed to have cancer recurrence after radiotherapy?
Yeah, so now we have the better MRI scanners, and we have PSMA PET scan, and I recommend that both are used. So when we talk about biochemical failure after definitive treatment, meaning let's say biochemical failure or PSA failure after radiotherapy, then PSMA PET scan is able to actually guide us correctly in 2 out of 3 men. And we see that PSMA PET scan is able to localize the disease and change treatment decisions in almost 50% of men. This is slightly different from numbers that you would see where the cancer has not initially been treated. treated. So for example, if it's a new cancer diagnosis, never been treated before, those numbers are slightly less. But when a cancer has been treated with radiotherapy and PSA starts rising, PSMA PET scan does become very powerful. The other thing is we also need to do an MRI scan in these cases if we suspect that cancer is recurring within the prostate. So because we need that MRI scan knowledge to plan biopsies, and in around 10% of cases, a PSMA PET scan would be negative, but an MRI scan would still show some, areas of activity or change, which can then help further pinpoint cancer. So a combination of PSMA PET scan and MRI is what we need, and then it all helps you to guide management appropriately.
Okay, very good. And what are the different salvage options after cancer recurrence following radiotherapy, assuming cancer has not already spread to other parts of the body?
Yeah, so this is where patients would benefit from being counseled appropriately. So historically, we would offer these patients just either watchful waiting or just intermittent hormone therapy, because even if you read the cancer treatment leaflets now, they still mention that if cancer returns after radiotherapy, then it's difficult to eradicate or surgery becomes very difficult. So, essentially clinicians and patients would essentially just give up. They would just say, fine, it has recurred, so it's now hormone therapy or nothing for me. But now we have over years come to understood that salvage options after radiation failures are woefully underutilized. There is a huge potential for their use, and there are basically two types of treatment options that we can offer. So they are essentially divided into two categories: whole gland options and focal options. So the differentiating factor is that if cancer is recurring within the prostate, is it recurring only in part of the prostate, or is it recurring in multiple areas within the prostate? So if a cancer is recurring in multiple areas within the prostate, the whole prostate still needs to be treated again. While sometimes if cancer is only recurring in part of a prostate, then we can get away with treating only that part of the prostate and still leave the rest of the prostate intact. Now, if you think from a scientific standpoint, if you are not treating the whole prostate and only part of it, then the side effect profile automatically goes down drastically. So to categorize, whole gland options include removing the prostate surgically. It's called salvage radical prostatectomy. Or you can burn the whole prostate down with ultrasound energy. So we deliver ultrasound energy, heat the prostate up. Or we can freeze cancer down with cryotherapy. Or we can re-irradiate the prostate again by brachytherapy or SABR these days. So there is also an option of re-irradiation, which should be offered in eligible cases. If cancer is recurring only in part of the prostate, then of course you don't need to remove that prostate, although that is also an option, but you can get away with salvage brachytherapy, cryotherapy, or HIFU. And right now people are even trying only salvage SABR. So just, a part of prostate would be treated in a focal manner with SABR, although this is the most latest, least tried option yet. So the whole gland and partial gland salvage options, surgically or via other minimally invasive methods, we have them today.
Okay, very good. I suppose then that leads on to just asking what the nuances to choose between the different treatment options in terms of the whole gland and partial gland salvage options.
Yeah, so regarding treatment-related nuances, so like I explained, of course, if the cancer is only recurring in part of the prostate, you should ideally, only treat that part. So if it is a unifocal disease, and if on biopsy and radiology, it matches, so on the scan, you see that lesion is only in one part, and then on the biopsy, where you biopsy both the cancer and the non-cancer bearing areas, and you find, yes, this is the cancer, it's only there, then you can treat them with focal salvage options. And if you find, sometimes what happens is cancer comes back in the prostate, but it also is in limited areas outside the prostate. So we call it oligometastatic disease. Now this is important. So if cancer has not yet spread too far, too much, too wide, there is still merit in treating the prostate. So patients still have, they can still have hope. There is no need to give up. Even if it has spread to 3 or less sites outside the prostate, we can treat prostate alone as well, along with focused therapy, radiotherapy to the 3 metastatic sites. So again, focal salvage options can be offered even in an oligometastatic setting, because you don't want, that cancer has already spread, but not too much. So we just need to reduce cancer burden as much as possible. So focal salvage options these days, with much reduced toxicity profile, are, we find more and more patients are actually eligible for it. Of course, those who have multifocal disease, those, who, then they would need whole-gland therapy options. So if we talk about individual options, now when a cancer recurs after radiotherapy, then obviously the most obvious curative theoretical option is to remove the prostate, just get it out, and then it should hopefully be sorted to the best ability. But the problem with that is, because the side effect profile is so bad, that currently the European Association of Urology recommends that salvage radical prostatectomy should only be offered in patients who have organ confined cancer less than T2B, whose Gleason score is less than equal to 7, whose PSA level is less than 10, and then who have a life expectancy future of 10 plus years. So if you add all these stringent criteria together, then you will find that a lot of patients are actually ineligible for salvage prostatectomy. So it's only a few good men that really do benefit. And of late, yes, historically, we would say that incontinence rate was very high after salvage prostatectomy. It would be 20 to 80%. Stricture rates were up to 40%. Rectal injury rate was 12.5%. But now we find that these rates are much lower in, as our experience has grown. But these are good only in cases where the cancer is not too aggressive. Now, radiation therapy these days is being given in more and more aggressive cases. For those cases, I think salvage prostatectomy is not really an option at all to begin in the first place. So then we have to depend upon other options, including salvage whole gland or partial gland HIFU and cryo, and I do these treatments. And while to do a salvage prostatectomy, you need a highly experienced surgeon who has done 1,000 plus cases of index prostate cancer and is very good at his job. It's such a difficult to scale treatment that you just can't find the right surgeons for it to train. It takes years to train to that standard. Salvage HIFU and salvage cryo treatments, they have got a similar 5-year cancer progression-free survival, similar long-term survival compared to salvage prostatectomy. It's much easier to learn. It's much easier to train. Just with a 6 months to 1 year of fellowship, you can learn these treatments, implement in your practice, and patients can and these treatments can be given irrespective of the Gleason grade. These can be given irrespective of other considerations where salvage prostatectomy just can't be done. So when it comes to salvage HIFU or cryo, we are happy to do it up to T3A disease, while prostatectomy can only be done up to T2B. With higher risk disease, it fails more often. In HIFU or cryo, you can treat glands up to 60 gram size. Those that are above this size can be shaved off with TURP, and then we can treat them. The long-term outcome wise, we see that 2 out of 3 men are actually cancer progression free and ADT free at the end of 5 to 6 years, which is an excellent number. Mm-hmm. The major complication rate after salvage focal therapy is actually grade 3 toxicity events are rare, while it is much common with salvage prostatectomy. And people tend to, look at old data from old series. Look at the newer series that are there now. Salvage focal therapy, salvage HIFU, salvage cryo. The rectal fistula rate that we quote is 1 in 300. And grade 3 toxicity, again, like I said, is rare. And at 10 years, in our series, 69% patients had freedom from androgen deprivation therapy. When we talk about salvage irradiation, yes, you can do that as well with salvage saber or HDR brachy. I don't recommend LDR brachy as to re-irradiate. You should have HDR because the rectal toxicity rate with LDR brachy is much high. But the only issue is that if someone has had poor tolerance to previous radiotherapy, then you may not want to give another radiation therapy to him because then he may react still bad. The other thing is, if cancer has recurred within 18 months or 2 years of previous radiotherapy, you cannot radiate that patient again in that short interval. While with salvage, HIFU and cryo, these constraints don't apply. So it is what I want to emphasize to audiences. There is hope for patients when they fail their radiation therapy treatment. Please no longer, think that watchful waiting or hormone therapy are their only options. We have excellent salvage options available these days, which can give your patients, a 69% chance at being progression free for many years down the line. And then you can reserve your hormone therapy for later, give them much longer, much better lifespan with very low grade 3 toxicity rates. And it's such a scalable modality. Now we are training more and more fellows in Imperial and in UCL for these modalities, because these are much scalable modalities than trying to train a very high volume, high experienced robotic surgeon to do a salvage prostatectomy, which will still take him 4, 5, 6, maybe 10 years to reach that standard to do his first case. While with what we do, we can train, 10 fellows within a year if we need to. So the awareness needs to spread.
Yes. Listen, thanks very much for your time, and it was very insightful. Thank you.
Thank you, and thank you. Have a great day.